So welcome to my presentation on chronic obstructive pulmonary disease. It's a case study review based off my patient John. So John has been seeing me for obviously probably 3 years. Over the past 6 or so months I've noticed a deterioration in his functionality. So I've got 2 pages of case study review, which is this first one and this second one also. So currently John is taking 3 types of medication, which include salbutamol, furosemide and prednisone. I've also requested a copy of John's most recent physical and lab results from his GP, with the table below showing those. This review will cover 5 key questions, which are on the screen at the moment. So firstly I'm going to describe the changes in John's lung structure and function associated with his COPD. So firstly, what is COPD? Basically, Paul describes COPD as a chronic obstructive pulmonary disease, a disease state characterised by an inflow obstruction that is not fully reversible. So Barnes 2008 found cigarette-associated noxious agents injure the airway epithelium and drive the key processes that lead to the following specific airway inflammation and structural changes that we will be looking through in a second. And Wilms obviously found that most of the inflammatory changes will always continue even though smoking stops. So John's progressive deterioration in lung function and structure is the underlying issue with most people suffering from chronic obstructive pulmonary disease. John is experiencing some drastic changes to the functionality and structure of his lungs. A bit of an overview of what basically happens. Inflammation and fibrosis of the bronchiole wall happens, hypertrophy of the submucosal glands and hypersecretion of mucus, and lastly a loss of elastic lung fibers and alveolar tissue is what basically happens to COPD sufferers. So there are 2 types of obstructive airway disease. The first is emphysema, the second is chronic obstructive bronchitis. So the first condition we're going to look at is emphysema, and it comprises of a compressed bronchial duct, a collapsed alveolar sac, the destruction of lung structure, and also the enlargement of air spaces, which are evident here on this diagram shown. So in chronic obstructive bronchitis, you will see an increase in the mucus production, inflammation and swelling, which impacts the cells lining the airway, decreasing cilia, and the obstruction of small airways, and finally a chronic productive cough. And this sort of diagram here indicates these problems with obviously that narrowing in the wall and obviously the inflammation impacting air that can come in and out of that bronchial duct. So how is lung function in persons with COPD assessed? Predict what John's results would most likely be if these data were available. So lung function assessments. The first one and most important is spirometry. This is a measurement of airflow and sort of shows the obstruction present. This can be done using FEV1, which is a forced expiratory volume in 1 second, FVC, which is a forced vital capacity, and then a ratio can be found of both of those, which is an FEV1 to FVC ratio, which is a percent of the maximum amount of air that the person can blow out in 1 second compared to the amount of air that they can expire in one breath. So the results are compared to reference values based on age, height, gender, and race. Okay, so this is possibly what John's results would look like if you were comparing him to a person exactly the same as himself, but without the condition. So assuming he took this reading, you would see something similar to the unbroken line, in which case he is breathing in at about 3.5 to 4 litres in one breath. You'll also notice comparing himself to someone that didn't have the condition, he's not able to breathe out as much of that air in 1 second. So he's he's going to see a drastic decline in possibly the amount of air that he can get out in 1 second, which is obviously an indication of an obstruction in that lung. Now, what you'll also notice is that the normal person can breathe out obviously a significantly higher amount of air. Now, this is a great indication of the functionality of that lung. It is able to produce more air in that lung, so it's bringing in more oxygen, but it's also able to breathe out a lot more carbon dioxide, so you're not getting that drastic build-up in carbon dioxide in the blood. So apart from spirometry, there are a few additional tests that should also be carried out. These include the following. So imaging, chest x-rays can be used to establish the presence of comorbidities, or along the lines of radiological scanning can also pick up on like hyperinflation, hyperlucency of the lungs, and tapering of vascular markings. So lung volume and diffusing capacity. COPD patients can experience gas trapping, which is obviously reside in residual volume, and can be measured a few different ways, which are obviously shown below just there. Oximetry and arterial blood gas measurements can be used to evaluate oxygen saturation and assess patients under FEV1 predicted or with signs of respiratory failure. John had this test done and he got 77 milligrams. So exercise testing should be done again as well, which we will cover sort of like in the next slide. So in terms of exercise testing, the first point of call should be via treadmill or ergonometer in a lab setting, and obviously 6-minute walk test can also be done if equipment isn't available. Explain the significance of John's resting heart rate, blood pressure, red blood cell count, and hematocrit. Explain why he's experiencing increased dyspnea during physical exertion and a greater increase in heart rate and blood pressure than typically expected for the intensity of work performed. So based off these, obviously everything is high. The resting heart rate 102 beats per minute. This is high because his heart is having to pump more times to ensure a sufficient supply of oxygen to parts of his body. Blood pressure. Pulmonary hypertension. This is common in sufferers of COPD for obvious reasons. The arteries that bring blood to the lungs are met with considerable sort of resistance due to the narrowing of blood vessels and capillaries. This is caused by the degeneration of lung tissue. So John has a high red blood cell count and obviously hematocrit level, and the reason for this is because his body's natural adaptation to that loss of oxygen is to create that extra blood, and because he's experiencing that hypoxia due to the degeneration of lung tissue, he can't get enough oxygen to parts of his body. So the extra blood cell count and the hematocrit percentage are obviously indications of that. John is experiencing increased dyspnea due to the lack of oxygen. This is evident by his lab results indicating that he is struggling to maintain sufficient oxygen levels in his body. Obviously i.e. high red blood cell count, hematocrit, increased resting heart rate and high blood pressure. As he exercises, his muscles need that oxygen, and this will obviously increase his need to intake oxygen. And this translates to that need of oxygen, resulting in him obviously having to breathe harder and with more force to try and get that air in. So John is seeing an increase in his heart rate and during physical exertion because of the limited oxygen-rich blood flowing through his body. This is largely again caused due to the degeneration of the efficiency of his pulmonary system. His blood pressure, of course, will increase due to the need to provide oxygen-rich blood to the body, and as stated before, the degeneration of that lung tissue means that efficient flow of blood via the arteries into the lungs capillary network will be reduced. Obviously, this is going to increase the systolic pressure. What is the mode of action of John's current medications, and how do they contribute to his treatment? The aim is to induce bronchodilation, decrease inflammatory reaction, and also to manage and prevent respiratory infections. Salbutamol, the mode of action is obviously on the screen at the moment. The uses for treatment obviously are to induce bronchodilation, which will allow John's airways to relax. Furosemide, obviously again the mode of action is on the screen. And its uses in treatment are to, again, like salbutamol, induce bronchodilation, and that's going to allow John's airways to relax. Prednisone, the mode of action is on the screen. And its uses are for the treatment as a corticosteroid, and also that's going to treat inflammation. Okay, so now I'm going to describe the potential long-term consequences of severe COPD on the cardiovascular system. Basically cardiovascular disease is a major factor in the long-term health of an individual suffering from COPD. I want to before I go into too much detail, just say that there isn't a lot of research that does indicate that, or why this sort of thing does happen. That there is, sufficient evidence to say that, COPD does obviously have its impact on cardiovascular disease. However, that they are still trying to come up with, a generalised fact of why that is happening. But what I will touch on is some of the most popular theories of it. So before I get into that though, the lungs and the heart function as a team. Obviously it's the same with most of the organs in the body. However, obviously it's more so important with these pair because the lungs supply that oxygen to the heart, and the heart supplies the blood to the lungs. So when one of those two do struggle, they do feel each other's pain, and hence the reason COPD sufferers are so susceptible to cardiovascular disease. So why is this? Well, low oxygen levels in the alveoli cause the pulmonary arteries to constrict, increasing the blood pressure, which is obviously secondary pulmonary hypertension. In which case, obviously, the right side of the heart must increase its workload to get blood into the lungs, and this workload will lead to ventricular hypertrophy. And this is obviously an extended period, or over an extended period, will lead to like a heart failure and cardiovascular disease, based off some of the studies that were conducted. So some cardiovascular issues with COPD sufferers do include heart failure, atrial fibrillation, ischemic heart disease, hypertension, stroke, and arrhythmia. And a study by Sin, McAllister, Mann, and Anthosian looked at the adaptation of cardiovascular issues in COPD sufferers as relating to systemic inflammation. So what they found was that FEV1 results under 50% of predicted would actually increase the probability of having elevated C-reactive protein in the systemic circulation when compared with normal lung function. So basically, obviously, this means that it is a negative effect of cardiovascular system, leading to some of the issues stated previously, such as heart failure, etc. And thank you for listening to this presentation on John, and here is the reference list.